Our next speaker is Dr. Sathish DEVARAJAN.
Good afternoon. Fungal keratitis is a leading cause of ocular morbidity and blindness throughout the world. So in our study, we compare the treatment outcomes of advanced fungal keratitis following intrastromal ozole alone versus intrastromal voriconazole with 9 milliwatt per centimeter square of PAC-CXL versus intrastromal voriconazole with 18 milliwatt per centimeter square of PAC-CXL. So we already know that cross-linking can strengthen the cornea by scarring. Photoactivated chromophore, that is riboflavin, is microbicidal, and that substantial evidence in keratoconus progression being retarded by cross-linking, and there is a reduced need for keratoplasty in keratoconus. But there is not enough evidence to show the same in microbial keratitis, especially fungal keratitis. The previous studies have shown mixed responses. Most of the studies have used the Western protocol. So in our study, we try to find out whether changing the protocol works, and we look at the role of intrastromal voriconazole and can the need for therapeutic keratoplasty be reduced. So major reviews and RCTs suggest careful modifications of treatment parameters such as irradiation, duration, type of chromophore, and fluence used might help to increase the microbicidal efficiency of the PAC-CXL. So our study is a retrospective cohort study, and 15 patients were assigned to each of the following groups and were followed up for every week for a month and then 2 weeks thereafter till 3 months. In group 1, we included patients who underwent antechamber wash with intrastromal and intracameral voriconazole. Group 2, we added 9 milliwatt per centimeter square for 10 minutes of PAC-CXL, and in group 3, along with this, we added PAC-CXL for 5 minutes with the fluence of 18 milliwatt per centimeter square. So we included all the patients who had microbiologically proven fungal keratitis who were refractory to medical management with an ulcer size of up to 8 millimeters of diameter, not involving the limbus with or without hypopyon. Informed consent and IRB approval were obtained. We excluded patients with a large descemetocele perforation or limbus involvement. And we also excluded patients with viral keratitis or other forms of parasitic keratitis. We excluded autoimmune diseases and ophthalmitis, pregnant or breastfeeding patients, patients who are less than 18 years, and patients who are not coming for follow-up. So under topical anesthesia, all the patients underwent superficial debridement, antechamber wash, intrastromal and intracameral voriconazole. In addition to this, group 2 and group 3 patients, 0.1% isotonic riboflavin was applied for every 2 minutes for the first 30 minutes and then for additional minutes. So group 2 received 9 milliwatt per centimeter square of UV radiation for 10 minutes, and in group 3, 18 milliwatt per centimeter square UV illumination was used for 5 minutes. After PAC-CXL, we continued maximum medical management. So the outcomes measured, complete healing was described as the resolution of ulcer, re-epithelialization of corneal epithelial defect, and stromal scarring. Treatment failure was described as non-resolving, extending to limbus, and perforation. Most of our patients were above 50 years of age, were diabetic. Ulcer size was more than 5 millimeters, and there was hypopyon. No patients were immunocompromised, and their blood sugar levels were kept under control during the study. At the end of 3 weeks, 7 out of 15 patients in group 1 resolved with early scarring, 7 out of 15 patients resolved with early scarring in group 2, and 10 out of 15 patients resolved with early scarring in group 3. So for patients who worsened, they underwent therapeutic keratoplasty. 8 patients in group 1, 8 patients in group 2, and 5 patients from group 3 underwent keratoplasty. Among these, 4 patients in group 1 had a perforation, and 1 patient in group 2 had a perforation, but surprisingly in group 3 there were no perforations. So when we did the statistical analysis, none of the group comparisons shows any statistical significance. However, due to the limited sample size, we are unable to achieve sufficient evidence. So we would like a sample size of at least 60 to achieve statistically significant outcome. So in group 1 and group 2, the outcomes were similar. So additional PAC-CXL did not improve the outcomes, but there was lesser perforations in group 2 and no perforations in group 3. Although the p-value is 0.2, the better outcomes in group 3 need to be studied further with a larger sample size. So does increasing the intensity of PAC-CXL have an advantage? Maybe. It might be more microbicidal, and addition of voriconazole also it enhances the UV-induced DNA damage by inhibiting catalase and promoting oxidative stress as evidence in dermatology studies. So our study, the strengths, it was concluded on exclusive on fungal keratitis with large ulcers refractive to medical management. But the limitations are a small size, single center, and it was not masked, and it was not a randomized control trial. Thank you.
Yeah, good presentation. And I want to ask, like, following PAC-CXL, was BCL also applied in the course of management?
No, ma'am. Because we left, since it is an infected case and we wanted to continue medical management, we didn't put BCL, ma'am.
No other questions from our judges?